everyone to iAfrica Media, the biggest media platform for all things eye care on the African continent. I'm your host, Obinwanne, all the way from South Africa. And today is one of those interesting interviews that we get to do as iAfrica Media because I'm sitting with another Obi, but all the way from Nigeria. And I know Dr. Tom Arnold from the United States of America. There's been occasions when he's communicating with you, Dr. Obi, thinking that he's communicating with me, or vice versa, where he's communicating with me, but in actual fact, he was communicating with you, because I think he goes onto Facebook and he just clicks on Obi and your name comes up first. So, Doctor, how are you?
I'm fine, thank you. Thanks for having me.
It's only a pleasure. I think it's been long overdue. We have been connected with you on the different social media platforms, including LinkedIn, over a few years now, and we have been admiring your work as iAfrica Media. We are inspired by your level of commitment and determination when it comes to elevating eye care on the African continent to greater heights. So having the opportunity to be able to sit with you and have this conversation about your journey in eye care, it's a complete honor for me personally.
Pleasure. It's a pleasure to be here.
Doctor, as I was preparing for this interview that we were doing with you, I realized that you are a man with many, many talents. You are well accomplished in a very short space of time. I'll give you an opportunity right now to tell people about your journey, but I see here on your profile on LinkedIn how much passionate you are when it comes to education, furthering your education. And I mean, just by going through some of the certificates that you have attained over the last few years, you have a certificate whereby it says you're a GCP for clinical investigations of devices, a certificate of completion in health, safety, and environmental. You've got a certificate of honor and recognition for the fight against counterfeit drugs. That's very, very interesting. I would love to know more about that. You've got a certificate of completion from the Kerasoft IC online training, and you've got a certificate in training, also a certificate of completion with regards also keratology, which it's very, very amazing that we have leaders such as yourself on the African continent going in that route of orthokeratology, scleral lenses, and so forth. And of course, you are a fellow of the Scleral Lens Education Society and a fellow of the American Academy of Optometry. Where do you get the time to be studying and furthering your education whilst still practicing and building this phenomenal eye care career?
Well, I usually just say I'm still young, so I can do a lot. I don't have that much responsibility holding me back. So I'm passionate about this. I'm passionate about cornea, contact lenses. So why not pursue it to the peak? So yeah, it's the passion that drives me.
When did your journey in eye care begin, while we at that?
I obtained my Doctor of Optometry degree from the University of Benin in 2012. Optometry wasn't something I planned out initially. Initially, I wanted to be a fashion designer. And yeah.
Wow, okay.
And my parents were, oh, no, you be a doctor, you be a doctor. So anyway. It was optometry, and I got in. I am the fourth optometrist in my family, actually. Wow. So I had a little idea of what optometry was, but it wasn't something I was really interested in initially. But as the years went by, more especially in my second or third year, I started to fall in love with optometry because it began to make sense. Everything started to tie up together. And it became really interesting, and I was more driven by the knowledge to know more rather than just get good grades. So I wanted to know more. Wow. So when I, in my fourth year, I think it was fourth year when we had started learning about contact lenses, rigid lenses to be specific. And I remember being blown away by the fact that you could place a rigid contact lens on the cornea and it would neutralize corneal astigmatism through some weird mechanism. And that was so interesting. And from then on, it didn't matter what you said to me, it was just cornea contact lens, straightforward. So when I finished in 2012, I did the compulsory national youth service you have to do in Nigeria. So that was 1 year. I was fortunate enough to get it done in a multidisciplinary health institution where you had ophthalmologists, optometrists of different specialties. So that also helped in pushing the interest further. And then I went on to do a clinical fellowship, a long-term clinical fellowship at the LV Prasad Eye Institute in India. Wow. So that was about 1.5 years, almost 2 years. So that covered, it was a fellowship in cornea and contact lens. So that covered cornea, specialty contact lenses, refractive surgery, cataract, emergency eye care. So that was 1.5 years. So that was where I really got to explore contact lenses, cornea, refractive surgery, orthokeratology, scleral lenses, pediatric contact lens fittings, and also clinical research. So that was where the interest came from, because the institute is research driven. So it was like a meeting point between clinical care in cornea and refractive surgery.
Wow.
And research, rather.
Wow, that's, I don't think a lot of people, especially young people, are fortunate enough to be exposed to such a diverse clinical environment at such a young age, because I think that obviously then broaden your perspective or your view pertaining to optometry as a whole and what direction that you would want to take it. So when you got back to Nigeria then, are you currently in private practice or public sector optometry?
So I'm in private practice, so I'm in a group practice.
Okay.
So in the practice I'm in, I handle cornea contact lens related cases. We have a low vision specialist. We have someone who's specialized in binocular vision, orthoptics, behavioral optometry, and then we have a general optometrist as well. So we have different specialties. So I handle the cornea and contact lens part when I go back to Nigeria. So I joined the group practice.
Wow. And in you then focusing specifically in cornea and contact lenses as a whole, or the anterior segment as your area of interest, a lot of the management options pertaining to that tend to be fairly expensive. I know here in South Africa, for example, a lot of the times patients will opt for spectacles as compared to contact lenses as their first option or first solution or preference. And many optometrists as well tend to not go in that route of contact lenses unless they are working in a contact lens driven environment. You then having a passion for the cornea, the anterior segment, contact lenses as a whole, how has that influenced the way you manage the patient on a day-to-day basis? And do you find that patients in Nigeria are open to both having contact lenses and spectacles as their management options to solve their visual problems?
Well, I think that's a very important question. And the reason I say that is because a lot of practitioners usually make up their minds for the patients. The patient may not have said they can't afford this service, or they might not be able to do that, but the practitioner may just be the one who thinks that way. I'm fortunate to practice in an urban area. So I practice in Abuja, which is the capital of Nigeria. So yes, there are people who can afford those services. But that said, most of my patients are actually not patients who are seeking contact lenses for elective reasons. So they are mostly medically necessary contact lenses. So I usually would treat patients with keratoconus, pellucid marginal corneal degeneration. I treat patients with Steven-Johnson syndrome, that's scleral lenses. I treat patients with severe dry eyes, patients even down to patients who may have undergone trabeculectomy surgery and have a bleb leak. and we use scleral lenses to put tamponade on the bleb. And then, so most of the patients I'm treating are for medical reasons. There's a genuine reason why they need contact lenses. Yes, there are those who elect or opt to have contact lenses as an option instead of wearing spectacles. But even in that set, I usually borrow my practice in that regard from clinical evidence. I read a paper once during my fellowship on how they had, was a practice, a private practice, where they were trying to boost up contact lens sales. So for myopic patients, when it was time to select frames, they had offered them diagnostic trial lenses to place on the eyes, and then you go select your frames. And a huge, if I remember correctly, over 60% of the patients ended up getting contact lenses and spectacles as well. So sometimes you can be proactive with these things. So I find that that helps. You build a bank of lenses, and then sometimes you offer trials, and these patients end up obtaining it. Also, with the current myopia boom, a lot of parents are now more receptive to contact lenses for children, especially knowing that the published data shows that the complication rate in children wearing contact lenses or even orthokeratology lenses is not as high as we thought it would have been. It's somewhere around less than 10 per 10,000 population. So the point is, yes, there is a medically necessary contact lenses. There's also the part where we fit for myopia control, which is gaining more ground in terms of multifocal contact lenses, orthokeratology, and also the elective ones. So it depends on how you're projecting to the patients about contact lenses. So sometimes I would have, like what you said, yes, some patients can't afford these lenses, honestly. And sometimes we just do the trial. For example, you have a keratoconus patient referred in, and maybe you have to fit an RGP or a corneal RGP or a scleral lens. And at that time, they might not be able to afford it. But these patients go back knowing the vision that they had gained. It's really life-changing because we call scleral lenses like the game changer. You place it on an eye of someone with advanced keratoconus, and sometimes you see real tears. Sometimes it's a patient who has Stevens-Johnson syndrome and they get that pain relief, improved vision, comfort, and you see the emotions pouring out. They might not be able to afford it at that time, but they usually go back, put the money together, and after some time they come back. So do your job well, do the trials. I always encourage diagnostic fitting. So you do the trials and the patients have a first-hand experience of what they're going to gain. So place the lens on the eye, and then usually the lens does the magic itself. You don't need to even do too much talking.
One thing that, as I'm listening to you speak, that comes out from what you say is that it's more about the quality of eye care management that we provide as compared to the quantity of eye care management that we provide. And that with every single patient that walks into the practice, you are literally taking them on a journey. This is, sir, ma'am, this is how you came in seeing in the practice. This is where you're supposed to be seeing. And this is what we are going to be doing to get you to that level that you need to see in. In us getting you to that level, it might involve contact lenses or spectacles, but in most likely option would be a multi-faceted approach in ensuring that you have the most adequate vision that will suit your visual requirements and needs. So it means you taking time with each and every single patient, educating them beyond just performing the long list of diagnostic procedures that we need in order to come up with what is wrong with the patient. It means you are spending a lot of time educating the patient in terms of what they need to be aware of pertaining to their vision, how we're going to manage them, and the journey that's going to be involved in managing that patient, which is very, very important. So I actually like that approach quite a lot. Now, in you being in such a clinically driven environment, working for a group which has other different components in it, is there pressure for you to then chase sales, targets, numbers? How does that play a role within the working environment right now?
Well, I think I'm the one who puts pressure on myself. So I set the bar for myself and then I try to beat that and I keep going. So there is nobody chasing me. So I have full autonomy of my specialty. I run it the way I want to run it. But I'm the one who sets the bar for myself in terms of the clinical research I try to put out, in terms of the services I offer to the patients. It's all about creating that experience, because sometimes they might forget, how much they paid for a particular product, or how much time they had to wait, or how long the consultation took. But it's the experience the patient gets. So I'm the one who keeps setting the bar for myself and try to beat that. So there's no pressure in terms of sales, because I'm not working for a retail company. So it's a private clinic practice, but I'm the one who keeps setting the bar up. So try and beat that each time.
Wow. That is fantastic, because that means then there's a leadership component that is involved in you working in your environment. There's a business mindset approach where you understand what it is that you are building, are creating within the dynamics of the overall group as a whole. How is the working relationship with other departments within the group? Let me put it this way. With you guys being in a group, how many optometrists are in the practice or in the center?
Presently, we have 4 optometrists. So I do corneal contact lens. We have the one for binocular vision and behavioral optometry. We have low vision, and then we have 1 general optometrist. But we also have interns, clinical observers, people who come for short-term training, externs, things like that. So as of now, we are 4 full-time optometrists. We have 1 intern, 1 extern, 1 observer. So that makes us about 7 total. But again, people come in, there's always a flow of people coming in to learn stuff in the practice.
Would you say that that type of environment is what actually makes the ideal optometric practice?
I would say, because you get to have a very wide view. For example, sometimes we cross-refer patients. I have patients sent from the behavioral and binocular vision unit, sometimes for contact lens fittings, which may help with a patient experiencing diplopia in certain specific cases. Sometimes we're doing for a patient who may be having very slight ISO, and we know orthokeratology lenses tend to make the eye slightly exo, and the patient is really opting for that. We move to orthokeratology. So we cross-refer patients. Sometimes I may have provided comfort to a patient with Steven-Johnson syndrome, and the vision improves up to an extent, but then the rehabilitation and low vision unit takes over. So you give the patient the best experience that they can get in a holistic environment. And also, we do also cross referrals, even though we don't, we have co-management agreements with different ophthalmologists with different specialties. A huge part of my referral actually comes, I think over 60% comes actually from the ophthalmology section, and also from general medicine, dermatologists, rheumatologists who deal with some of these patients with severe ocular surface disease. So it's a whole experience, like a whole team, and with the patient in the center of it, getting the best care. So yes, being in a group environment gives the best to the patient.
So, I mean, I know a lot of people are going to be watching this. If you are a young optometrist, I would definitely recommend you investigate options of you building a clinically orientated practice as compared to just having a generic general optometry practice, because you are able to broaden your scope of offering when you are in a clinically orientated environment. It just gives you capacity in terms of what you can do, because with technology, and I'm sure you have seen this within your working environment, technology always comes and addresses, especially from a consumer point of view or from a patient point of view, things like spectacle frames. It's easy now for a patient to go online, order a pair of spectacle frames, and they can get them delivered to their homes. But with regards to clinical optometry, there's so much more that's involved in it that the optometrist still plays a critical role in the decisions that a patient will make pertaining to their visual needs. So I encourage every young person who's thinking, or actually every optometrist who's thinking of establishing their own optometry practice, consider the clinical route, because honestly speaking, we don't have enough of optometrists within that space. We've got so many optometrists in the space of clinical optometry, in general optometry. Now, you mentioned 60% of your referral system comes from ophthalmologists. So I take it that you are working, or you are having professional relationships with multiple ophthalmologists within your community as compared to just having one. How do you go about establishing a trust relationship between yourself and the ophthalmologist? How is that current relationships with the different specialists that are in the area?
First, I'd say I have been lucky to work, or I've always, every time I have practiced, it's always been in a multidisciplinary approach practice or setting. Right from the days of my clinical internship, we had, I think, 3 ophthalmologists in the practice in the hospital where I did my internship, to the point of my fellowship. During my fellowship was where I really got to learn co-management. So like I said, I did my fellowship in cornea, contact lens, anterior segment. So you have a lot of ophthalmologists in that setting. But what really has helped me establish them is, first of all, networking. So you take that leap, you go forward, speak with the ophthalmologist. I know there is this unspoken fear or rift sort of between both careers, but it doesn't have to be, because I'd say probably because I'm used to working with them, I don't see that I am encroaching in your space. So everybody has their defined roles, actually. But when you go and you speak to them and you show the services, or you discuss the services that you offer with the patient in mind, I think it's a win-win for everybody, because first, once you establish that networking relationship and you explain, or the ophthalmologists understand what you're offering clearly, especially when it's something that's going to be beneficial to their patients. I'll give you an example. When I got back to Nigeria, I made a list of the ophthalmologists who were around the practice, and I went to meet them individually, discussing these new options, because then nobody was fitting scleral lenses, things like use of bandage contact lenses, or the therapeutic use of scleral lenses, or corneal RGPs for patients with corneal ectatic conditions, or patients who may have had corneal transplantations and they ended up having irregular astigmatism. And due to the higher order aberrations, vision is not so clear with spectacles. So it's creating a niche or an environment where service wasn't being delivered. And you have these people opening up and saying, oh, this is great. I never experienced any pushback, actually, for many of the guys. In fact, I did give a lecture to the Ophthalmology Society of Nigeria, the chapter in the state where I practice, educating them about optical uses of scleral lenses and therapeutic uses of scleral lenses. After that CME lecture, I think that was when my referrals actually shut up. So yes, I give lectures to the optometry colleagues as well. That's a constant ongoing thing, but also it's important to reach out to the guys in the other side of the aisle too, because at the end of the day, we all want what's best for the patient. So as long as you're sure about the service that you offer and you're sure of yourself, you have been properly trained in this area, which is very important, getting that knowledge. Once you are sure of yourself, it's easy to project yourself forward and offer something that wasn't being done before.
Wow, that is absolutely fantastic. You mentioned, right in the beginning, we mentioned all the certificates that you have attained over the years, and this happened earlier on in your career. For someone who's listening in or going to be watching this interview, thinking to themselves, wow, I don't know where to get the information that I need in order to further my career. Because a lot of the times we become narrow-minded, or thinking that only the academic institutions where we got our optometry degrees are the only areas where we can further our education. in creating that niche that you were speaking about earlier on. How did you go about identifying institutions, organizations, where you can further your courses? Did you just go online? Were you following people? I know that you and I, a week ago, were attendees, online attendees of the ICSE conference in America that was hosted by Dr. Tom Arnold and Dr. Melissa Barnett. So, but we saw that online. So in you furthering your studies with all these short courses, how did you go about knowing where to get the information? Was it easily accessible, easily available? How did you go about doing that?
Well, the first thing I'd say, I think it goes back to networking. You have the interest, yes, but you need to be able to network with people who have like minds. I started, like I said, I started becoming interested in cornea and contact lens right from my 4th year in university. So yes, initially it started with me going online. Then mobile phones weren't that common, or internet services weren't that common. So I remember going to cyber cafes and just I kept reading review of optometry. It was mind-blowing the way they were practicing. And I always said, oh, I wanted to practice this way. And I started subscribing to certain journals like the Optometric Physician by Dr. Arthur Epstein, whom I consider a mentor. And I started learning the way these people followed or how they established themselves. So a lot of them I noticed were residency trained. They had some clinical fellowship or some clinical training. So I knew I had to get one of those. So what was the quickest way for me to get a clinical fellowship as soon as I was done with school? Because I didn't want any lapses. I wanted to keep moving forward. So I identified a couple of optometrists who were specialized in cornea, contact lens, anterior segments, and noticed they all went through some residency or clinical fellowship. And I started searching for one program before I finished my university. And as soon as I was done, I had emailed several schools, both in the US, in the UK, and India. So that was when LB Prasad came up, and I realized they were well renowned around the world for corneal research, corneal clinical services, and cutting edge technology. And it was less hassle to go to India and get trained. The emails went back and forth. And as soon as I was done with university and my national service, I got accepted into the clinical fellowship in anterior segment, which was a long-term one comprising cornea, refractive surgery, contact lens, cataracts, and all that. So after that residency training, it was like I became exposed to the world. But most of the networks I have today, or the people that we seem to have similar interests in, I actually learned about them or met them during my fellowship. Wow. For example, Nick Romney, I met at the, I think it was the World Congress of Optometry, the one that was held in Hyderabad in India. That was where I met him. And he was the one who talked me into even applying for the American Academy of Optometry Fellowship. So it was from there. Then I met other people when I started going down the ropes for the American Academy of Optometry Fellowship. Also, Dr. Tom Arnold, I met through my interest in scleral lenses. So right after my fellowship in, my clinical fellowship in cornea and anterior segment, I went ahead and did the fellowship in scleral, with the Scleral Lens Education Society. And that was how I met, got in contact with Dr. Melissa Barnett, Dr. Tom Arnold. And Tom Arnold has not only been a friend, he's also been a mentor. He's always been encouraging. So basically, these people I have met along the way because of similar interests and networking, but it does help to have someone who you look up to or someone who you admire, someone who has walked the ropes, and you can follow in that person's pattern. Also, you could look around for, again, programs that are around you. I know in Nigeria, here we have the Nigerian College of Optometry, where they also have, there's also a fellowship program in several specialties of optometry. Looking around the world as well, there are several programs out there. So first of all, I'd say identify what it is that you like doing. Then identify someone in that area who you can look up to. can walk the ropes just like the person. You might experience a couple of hitches along the way, but sure, keep making networks along the way and you just keep going.
Wow. You have literally touched on such a critical component of networking, because we already have people that have paved the way for the next generation. And a lot of the hurdles that they have already gone through, when we reach out to them, it makes it far easier for us to be able to get to a certain level far quicker than the journey that they took. Do you believe that we have enough Africans or African young people reaching out to those international leaders, like you have mentioned right now? Do we have enough of African leaders reaching out to learn from other markets, other industries, other areas? And that's the first part of the question. The second part of the question, the question then becomes, where do we measure up right now with the rest of the world in terms of clinical optometry? Yeah, that's the two questions I will ask you right now.
Well, I'd say we're still getting there. Optometry is not as old as in the United States or in the UK as it is in Africa. I know the scope of practice varies from one African country to the other, for example, with the education and the curriculum and everything. There's still some disparity, but I think we're getting there. It can only get better, actually. I think there's still a lot more that can be done, especially with teaching or having to teach young people or students about evidence-based clinical practice, because a lot of times you may still have people being taught very old techniques or old ways of doing things when there are better ways or newer methods of doing things. For example, the way the average dry eye patient in Africa will be managed may be different from the way that same patient will be managed outside the country. So I think what I would advise is adopting more evidence-based clinical practice in Africa, incorporating that into the education curriculum, more research. I'm a huge fan of clinical research. I run a journal club where we meet once a week and we discuss one relevant clinical research article every week. It's been running since 2018. So we have optometrists joining from different states, different parts of Nigeria. And the essence is to teach evidence-based clinical practice. So we learn from a research article. I'm also involved in clinical research in scleral lenses, myopia, ocular surface disease, dry eyes, and things like that. But I think at the end of the day, optometry here, in terms of clinical practice, can only get better, but we need to incorporate more evidence-based practice in our day-to-day clinical practice and education.
Wow, you literally answered that perfectly. We've got the myopia boom right now. We've got orthokeratology. Some of the advocates for orthokeratology, when they were busy going on and on about it 10 years ago, 15 years ago, there was no buy-in from African optometrists or practitioners. Scleral lenses, when they got into the market, it looked like a foreign concept to your general optometrists. But in the last year, we have seen a massive boom where scleral lenses, as you mentioned earlier on, provide you with both a therapeutic solution in managing the patient, but also an optical solution in managing the patient. RGPs, orthokeratology. Are we doing enough in attaining the necessary skills as practitioners here on the continent to be able to... Sorry?
I'd say no. I'd say no, we're not. No, we're not. I think, like I said, that drive towards educating yourself with what is the current standard around the world, what has been proven by research, has to be there. Otherwise, I think you alluded to something initially where you talked about moving away from that spectacle or refraction-oriented setting, because the truth is technology is only going to get better. So one of these days, we're going to have some online refraction thing. It's just going to keep getting refined and refined. So you have to set yourself out so you don't get left behind. So choosing a specialty is one of the ways. Moving forward in terms of getting the education, the necessary training, like you mentioned, orthokeratology, scleral lenses, because I remember coming back and talking about scleral lenses, and I remember people asking, who's going to pay for that? Or who's going to pay for the keratology? Well, I have people paying for that. That doesn't take away the fact that, yes, certain parts of the population in Africa don't have adequate access to eye care as they deserve. Yes. But there are also those who can actually afford this. But there has to be a meeting point between the demand for these services and what services you are willing to provide or offer. There has to be a meeting point. Yes, a patient might not be able to afford orthokeratology lenses, but there are other technologies that are devices that you have at your disposal where you can also manage myopia with low-dose atropine. I don't think we have a shortage of compounding pharmacists in Africa. I actually have them everywhere in the city where I practice. There are other spectacle options. So the options are there. You just need to educate yourself and understand what tools do I have at my disposal and be able to provide a wide range of services for those who can afford it and those who need it.
You know, one thing that I love about how you're responding to these questions is that you're giving specific examples of what we need to do, because a lot of people will look at what I do or what Dr. Glover will do on social media, and they will be mistaken to think that that is actually optometry, because we are so alive when it comes to marketing, branding, and all of that type of stuff. But patients come because of branding, marketing, and all of that type of stuff. They come because of your clinical expertise. When they're sitting in front of your chair, it is those clinical skills that you have in managing them, solving the individual problem, that when they leave there, you have given them the best experience of their life, you have changed how they see, and they're going to leave your practice to tell their family, their friends, their colleagues about the experience that they had. And I think a lot of optometrists, they miss that. They think that it's all about social media, building this amazing brand online.
Well, what you're saying, sorry to interrupt, but what you're saying is absolutely true, because I remember something from my professor in university who taught practice management. And she always said, if you please one patient, you're going to gain 10 more. And if you lose one patient, you lose about 100, because bad news does spread fast. But a lot of times, some of the referrals actually come from word of mouth. So if you give that one person that experience, and sometimes it may not always be giving some cutting edge technology, it might just be listening. You just keep quiet and let the patient express themselves. Absolutely. And sometimes that's all that patient needs. Sometimes some patients just need you to hold their hands and say, I'll take care of your eyes, you just show up for your appointment. Sometimes, yes, some patients need that excellent clinical cutting-edge technology. So every patient is unique. Look at what's in your environment and make the best of it.
Wow, I love that. I love that. I was actually very surprised last week when we were part of this conference in America that I was actually disappointed in the numbers of people that were coming from Africa. It broke my heart, honestly speaking, because it's not about us attending the conferences that side, but it's about us exposing ourselves to what's happening in the rest of the world and looking at opportunities and ways in which we can make it relevant for Africa. How do we then ensure that what we do as Africans is of the toppest quality, best quality, and that we are not creating a disadvantage to our patients with regards how we can manage them. So I hope that things change, that leaders like yourselves who are exposed to what's happening in the rest of the world, we can create more opportunities in expanding that knowledge for people to have access to. And as we're doing a podcast right now, one of the things that I can think of right now is we need to get you into our podcast. What are your thoughts on that?
Well, I'm always open to educating anyone, so I'll be happy to do a podcast for you anytime.
Because I think it will be a fantastic podcast if you had to do a podcast on a month-to-month basis, focused specifically on the cornea, the anterior segment, scleral lenses, orthokeratology, all things clinical optometry. I think it can broaden the knowledge base that young optometrists, old optometrists have currently, because currently you're doing a lot of fantastic stuff. But I think with Africa Media, it has connected all eye care professionals on the continent with each other. So you could have people from Zimbabwe, Nigeria, Namibia, Botswana, Mali, Cameroon, Kenya, connected to your podcasts, including people up north, Morocco, Egypt, connected to your podcast, where we can learn from one another in terms of what is best practice in one country versus what is best practice in another country, and as well as having that opportunity of getting overseas experts onto your channel, and we can learn so much from them, eh?
Well, I'm ready when you are. Just say the word and I'll jump.
No, let's do it. Let's do it. Let's do it. One of the things that I wanted to ask you about is, where do you see optometry 10 years from now on the continent? What does it look like for you 10 years from now?
Well, for me, optometry is going to look more, I think I'd probably become more narrow in terms of clinical research and cornea and contact lens and all that. I probably may reduce the time I spend with general patients. But in Africa as a whole, I think it's going to get better. I think the myopia wave hasn't pushed into Africa as much as it has in other parts of the world, most likely because we don't have so much data that shows how much myopia has changed over time. But I think it's just a matter of time. People are becoming more educated, more aware. There's several Africans going forward getting PhDs, even younger than I am. So I think it's just a matter of time before we're able to push that bar. And the next 10 years, I think myopia control is going to become a mainstay. We're all going to realize all those patients were fitting with single vision spectacles, or we probably shouldn't have done that at that time. We're going to see more contact lens fittings. We're going to see scleral lenses become more mainstream. And I think the lines between ophthalmology and optometry in the next 10 years in Africa is going to become closer or more blurred, because you're going to have more co-management of these cases in future. So I think it's going to be great in the next 10 years.
I agree with you. Just this past month of July, we had about 4 interviews that we did as Africa Media, including a webinar. And it was with ophthalmologists specifically who are doing groundbreaking work within their field. And all 4 interviews or webinars that took place, they kept on mentioning the future of eye care management of the patient is more co-management of the patient between dispensers, optical dispensers, opticians, optometrists, as well as ophthalmologists. And that's the future. And if we're not starting to embrace it right now, it's going to create a problem later on for patients. So we need to keep on going out of our way to work with one another. Now we're talking about clinical optometry, and a person is thinking, I actually want to go in this route for me to fine-tune my craft and have a niche within optometry through clinical optometry. The question that they're going to be having to answer is the financial implications that are involved in setting up a clinically orientated optometric practice, because there's lots of equipment that's involved. There's a lot of chair time that's involved when it comes to managing the patient. What are some of the equipment that you use in your optometric practice currently?
Well, obviously the traditional ones are still very important. So I wouldn't say I'm up there that much in technology terms. Maybe when I get my scleral topographer, then I'd say I'm up there in technology terms. But for me, the must-haves for a cornea specialist or someone who's interested in fitting cornea patients or specialty contact lenses, your slit lamp is extremely important. Again, I can't overemphasize that. Even sometimes, like Dr. Tom Arnold would always say, one of his friends says is, we are fitting scleral lenses, just put it on the eye and look at it under the damn slit lamp, and you know what to do from there. But the slit lamp is a must. Corneal topographers, I have that thanks to Dr. Tom Arnold as well. A retinoscope. In as much as autorefractors are all savvy and great, I am more comfortable with my retinoscope because it tells a lot. And I was very happy when I read the paper, I think it was in 2019 or 2020, published in the journal Cornea, I think it was in 2019, where they actually discovered that you using your retinoscope to detect scissors reflex can always help you over 80% of the times pick up keratoconus patients. So that also is important. So yes, the basics are important, and the other specialized equipment like your corneal topographers, anterior segment OCTs, which are very important for fitting scleral lenses. Now, scleral lens fitting is moving towards more of an empirical fitting, so we are relying more on scleral topographies or scleral profilometers and things like that. That's also the way to go. So those are in terms of the equipment that I find very necessary. In terms of the cost, yes, these equipments don't come cheap, but it is rewarding. So that I can say, because once you've started fitting some of these specialty lenses, like scleral lenses or orthokeratology lenses, it does pay back. I hope in future we have more of the equipment companies offering loans and services, or those kind of services to African optometrists to be able to build up their practice and then work out a payback system. Yes, the equipments are expensive, but they are really, really rewarding. So once you're educated in a particular specialty or a particular area, go ahead and get the equipment. It will pay for itself. You just have to network yourself, market yourself. I haven't regretted taking any loans for anything or moving forward or getting this equipment. It's amazing. I got an A-scan machine recently for myopia control, and it's been going up. So it's just get the knowledge, find a way, get the equipment, get that loan. If you have to get the loan, it will pay back. Just network yourself, it will pay back itself.
Wow, wow. Dr. Obi, wow. I'm blown away by the way you think about optometry. I think you are a fascinating leader, and I'm looking forward to how you're going to change the eye care landscape on the continent from a clinical optometric point of view. We are the next generation of eye care leaders who are going to transform how eye care functions on the continent as a whole. And thank you very much for unveiling your time. We look forward to greater things from you in the near future. And Africa Media, it's made possible because of leaders like you who unveil your time, who are not hesitant to just come and give off the knowledge, your skills, your expertise in growing eye care on the continent and exposing young people, the next generation of optometrists, to what is possible when it comes to optometry. And I believe that clinical optometry is such a massive opportunity. If people can understand that, yes, it costs a lot, but once you are in it, the type of patients that you see, the recurrence of patients that keep coming to you, that niche you might think is small, but patients that operate within a niche spend more money actually than those that come for general optometric services. Because the ones that come for general optometric services, they're always going to look for where the discounts are at. They're always going to be looking at where they can save money, where are cheaper options. But those that come for clinical related services, they trust the practitioner that they're dealing with, and they will keep coming more often than not because of that trust relationship that exists between you and them. So thank you for sharing the pearls of wisdom that you have shared with the platform today. We really, really appreciate it, Doc.
Thank you so much for having me. It's my pleasure.
Where can people connect with you? Are you on social media? Are you online? Where can people reach out to you?
Yes, I'm on social media. You can connect with me on Facebook, on Instagram. Facebook, it's my full name, Obinwanne Chukwuemeka Jnr. Instagram, Arthur Chionye, but I think we'll put that at the end of the interview. You can email me. I always respond to emails. I'm not so Twitter savvy. I don't do TikTok. I'm not that exposed or that young. So I don't know how to use those, but you can reach me on emails, Instagram, Facebook. Yeah.
Do you have a YouTube channel?
No, I don't, but maybe in the future that might be in the works, but right now, no, I don't.
I hear you. Thank you very much, Doc. Everyone, that was Dr. Obi, not this Obi, but that Dr. Obi. Thank you very much. If you're not connected yet with iAfrica Media on the different social media platforms, we are on Facebook, we are on Instagram, we are on LinkedIn. Do subscribe on our YouTube channel. And of course, connect with us on the website to follow all the amazing interviews, podcasts, blogs, articles, and the latest in eye care on the African continent. This is your host, Obinwanne, all the way from South Africa, and we look forward to connecting with you in your country, in your optometric practice. Let's keep working together, collaborating, partnering up with one another so that we can grow eye care on the African continent and take it to the highest possible level of excellence. Take care, everyone.